My name is Jocinta Whitney. My boss, Faye Kabigting, is not available, so she told me if I could come and do this for her, and I said, okay, I will.
Yes,
So I work at NASA University Medical Center since 1989. I'm from the Philippines, and I came over here as a nurse. So I was recruited, and I came, like a lot of Filipino nurses wants to come.
Yes.
It's like a dream come true for, and I bet you have seen a lot of Filipino nurses around. But anyway, as what I said, my name is Jocinta Whitney, and I'm going to present to you a comprehensive approach to healthcare-associated infection. Okay. All right. So our goal in every day as a healthcare provider is patient safety. Clean care is safer care. Okay. So can you change it? Sorry. I have the thing, but it doesn't fit. All right. So with this, starts with clean hands. I know it was already discussed earlier, and it's gonna be fast. All right. Clean environment, and another thing. This is gonna be fast. Okay. Clean patients. Okay. So we have our goal is always to have all these three. Hands is like a farm of organisms. Okay, we have to have clean hands all the time. Clean environment and clean patient. That's what I said earlier. Okay, so safe hand hygiene. It's not a choice to healthcare providers. Okay, it is our professional obligation as healthcare providers. Hand hygiene is the most effective measure to prevent the transmission of organisms and prevent healthcare-associated infection. Okay. Now the problem that we see all the time is that healthcare-associated infection are infections people get while receiving healthcare in the hospital. Okay, HAI, or the healthcare-associated infection, each year hundreds and millions of people around the world are affected by this. It is an adverse event in healthcare. Okay, and we have heard earlier that this is really, it's getting worse. This is like 2002, it says in there that 1.7 million hospital-acquired infections in the US hospitals happen. Okay, okay. So the problem is, in healthcare, organisms are everywhere and can be passed to susceptible patients, especially those patients that are immunosuppressed. Okay, they easily get these things. Healthcare workers, according to IHI, or the Institute of Healthcare Improvements, says that 50% only of all healthcare workers wash their hands, like truthfully. Okay, like according to CDC standards where we wash our hands 20 seconds, they're not everybody is like that. It's like 50% only complies to it. Okay, most hospital-acquired infections are transmitted by healthcare workers as a result of direct contacts through the hands. Organisms are transmitted from the environment. Okay, so safety goal number 7, as per the Joint Commission, implies complying with the current CDC or the World Health Organization hand hygiene guidelines. And we have to report hospital-associated infections like the vent-associated events, the CORI or the CLABSI. Okay, let me just say, CORI is catheter-associated urinary tract infection. CLABSI, or the central line-associated bloodstream infection, and the selected OR procedures, like the hip, the colon, the knee. Those are the things that CDC or that we report in the hospital to national places like the CDC, or especially the CDC. Okay, we also, in here is also the MDROs, or the multi-resistant drug organisms, the MRSA, the VRE, the C. diff, and the gram-negative organisms. Okay, now the sources of regulations for infection prevention and control. These are the people that regulates these things, the federal or the national. Okay, that's the OSHA, the CDC, the CMS, or the New York State Department of Health, and the private regulatory system, which is the Joint Commission. Right now, the hospital is preparing, being prepared because the Joint Commission will be coming, they say maybe March or April, so we're kind of busy in there with preparing the hospital. Okay, so, all right. So, infection prevention initiatives, we prevent infection associated hospital-acquired infection is, we prevent central line associated infection, or the CLABSI, prevent ventilator-associated events, or the GAHD, catheter-associated UTI, and surgical site infections. And also to reduce multi-resistant drug organisms. All this includes in the hospital-acquired infections. Okay, so in each of these events, like the CLABSI, the GAHD, the VAEs, we have bundles that we follow. So what is a bundle? Hospital prevention bundles. This is a group of evidence-based interventions when bundled or implemented together have improved patient outcomes. And these are the things that we do. Like for example, for the SSI or the surgical site bundles to prevent surgical site infections. The first one is we have to have appropriate use of peri-op antibiotics. Sometimes, as what the doctor said, that the empiric medications, we give like medication before they do the surgery. Appropriate hair removal is the second one. Third one is maintenance of post-operative glucose control for major cardiac surgery patients. Another one is maintenance of post-operative normothermia for colorectal surgical patients. Okay, the doctors also, they do DVT prophylaxis or the deep vein thrombosis prophylaxis, and discontinuing of Foley catheters 24 hours after surgery. Okay, sometimes it stays longer, but we don't like that because the more it stays in there, the more infection occurs. Surgical hand scrub, of course, before they go to surgery, they have to do that. Now, the central line infection, insertion and maintenance bundle, this is another bundle that we do. The first one is, of course, hand hygiene. 20-minute or 20-second hand wash, I should say. The maximal barrier precautions provider placing the central line, and for those assisting the procedure for the patient. Maybe you can go another. Okay. When a doctor would insert the central line, the doctor should look like this. From the head to the toe, it should be covered. And the patient also from the head to the toe, you cannot even see the patient anymore. I'm sorry, the picture is a little blurry. But they have to have the maximum barrier precaution. Okay, going back. I'm sorry, going back to where it was. Okay, and we use this CHG or the skin antisepsis called chlorhexidine. Okay, there is like 4% of that chlorhexidine in the alcohol, and they said it's really effective. Okay, optimal catheter site infection, which is subclavian. Most usually, when there's an emergency, they put it in femoral because it's the easiest they can find. It's big, and you know that's like for emergency situations, the doctors usually do femoral lines, but the best or the optimal selection is the subclavian. It's the preferred sites. Okay, and of course, daily review of central line necessity with prompt removal of unnecessary lines. Okay, sometimes the central lines stay with the patient for a long time, and sometimes it's forgotten, like it's there. Okay, because it's covered or you know whatever, and then it causes infection, which is reportable to New York State. And when there's a reportable thing like that, it's like the hospital is not reimbursed by CMS, and it's a big deal. Okay, so we don't like infections. It's really bad. And of course, keep the central line dressing intact at all times. Okay, now as you see in that picture, there's a circle, a round thing called the biopatch. Okay, so we place this, it's blue. The top one is really blue. Okay, this is how we know how to put it. Okay, the top one is blue, or we say it like blue to the sky, or the foam side down. Biopatch edges, because there's a slit to be able to put it together, it should be touching each other to complete coverage. And because it releases chlorhexidine slowly over 7 days when it's supposed to be changed already. Okay, so it is being replaced 7 days with dressing changes. Okay, CLABSI prevention. Okay, the bundle also includes maintenance. When a person has a central line, wherever part of the body would be, okay, and the nurses would always scrub the hub for 20 seconds prior to entering needleless connectors. Okay, so those, the first picture on the other side are the ports. Okay, the end of the port looks like the one in the middle, and this orange one in here is the swab cap that we cover the central lines. It has impregnated chlorhexidine in it, and it's a good thing. Okay, this is evidence-based practice that, you know, it really lowers down infection. Okay, for indwelling urethral catheter use, there has to be a reason why the patient needs a catheter, a Foley catheter. Okay, patient has to have an acute urinary retention or bladder outlet obstruction. Okay, there has to be a need for urine output measurements. Okay, or for selected surgical procedures, and to assist in healing an open sacral or perineal wounds. Okay, so at one point I was doing surveillance in the burn center in the hospital, and the burn was in the area here, in the perineal area, so it was really very hard to remove the Foley catheter right away. It has to heal first before, you know, we have to remove it. And patient requires prolonged immobilization and also to improve comfort for the end-of-life care. Now, catheter-associated UTI, we have bundles for that also. The first one is Foley catheter use, appropriate indication. We have to know the indication why this patient needs the Foley catheter. Okay, and there has to be an order and an insert documentation. Okay, and every day it has to be assessed whether this patient still needs it or not. Because sometimes, again, I would say it would be forgotten, and then infection gets in, and then the hospital is not reimbursed by CMS. So there's a lot of money involved when these infections occur. Okay, and then there's a question in there, number 4, is patient or family associated UTI prevention education documented? It has to be documented. We have forms that we give our patients and their family also to read what they have to do, because sometimes patients go home with Foley catheters. Okay, or when we insert the Foley catheter, is there a Foley catheter securement lock intact, or is the tamper-resistant seal intact? Okay, individualized covered collection bottle stored at bedside, because sometimes when we measure the urine, how much output the patient has, it has to be in that bottle, or we call the urinal we use. Okay, and it has to be the name in it so that it's not used by anyone. It's like a dedicated collection bottle. Urinary collection bag kept below the bladder, because when it's higher than the bladder, then it sits in. The infection sets in. And another one is the urinary bag off the floor, so it doesn't touch the floor. The outlet spigot kept in the housing. And documentation of Foley catheter and perineal care at all times. Okay. All right, these are the MDRO and epidemiological significant organisms that we usually see. We can go through all of those things. Okay. The MRSA, or the methicillin-resistant Staphylococcus aureus, the vancomycin-resistant Enterococcus, and other gram-negative organisms, the Klebsiella, E. coli, Clostridium difficile. All these are the ones that, the common ones that we see most of the time in the hospital. okay, or the ESBL, the extended spectrum beta lactamase producers. Okay. Now the ESBL, it has the capability of inactivating penicillins. Okay, the narrow spectrum cephalosporins, many extended spectrum cephalosporins, the oxamino group containing cephalosporins, the cefotaxime, ceftazidime, and the monobactams or the aztreonams. Okay, now we have a bundle for this too, for the MDROs. Okay, so what we do is that we have the monitoring program, including the lab-based alert system. Like when a patient comes in, or they haven't been tested, okay, they will be tested if they have the symptoms, of course. And it is a policy in the hospital that if a patient comes from a nursing home or a dialysis patient, they're tested right away also. Okay. Contact precaution signs are put in, PPEs or the personal protective equipment are used, hand hygiene again, patient is isolated right away, patient education provided, and proper environmental cleaning and disinfection. Okay, it has been mentioned earlier by the doctor that, you know, the surroundings. Okay, like for example, in the hospital, you are in a patient's room and someone called you like, my name is JJ, okay? JJ, the phone is ringing for you. And then I go right away, I didn't wash my hands, I pick up the phone and left and went back to my patient's room and nobody saw me. And then the next person would pick up the phone and it's all over the place. Okay, all the time in the hospital, we even encourage that when they would transport a patient from the room to x-ray or something, they cannot wear gloves. They have to wash their hands, bring the patient downstairs, because most of the time when the gloves is there, it has touched everything already. And it goes to the buttons of the elevators, it goes to the doorknobs. So what we always encourage is just wash your hands, it's very important. Okay? When the patient gets readmitted, it's already in the record that they have this infection, because in our department we have a record called the known list. For example, if the patient comes in and they have a record from a long time ago, like 3 years ago, we still have it, unless they're discontinued, that they're no longer have this organism in their body. Okay, we identify readmitted MDRO with positive patients per history, and when a patient comes with infection from another facility, usually we get something from them, and when they get discharged to another facility, we have to make sure that they know that this patient have it also. So it's like nothing is lost. Sometimes it does, but we wanted nothing to be lost, so there's no spread of infection. Go ahead. Thank you. Okay, so hand hygiene is the most important thing to prevent infections. At least 20 seconds, according to CDC. The nails is also, I can just imagine this picture on this side. Okay, head, all right? When an employee or when a new hired person comes to the hospital, we always look, the infection preventionists like us, look at the nails. Because, you know, it has to be less than 1/4 of an inch. You can have polish in it, nail polish, but it cannot be chipped. No gels. Okay, just regular nail polish. Okay, and this is the way how to wash your hands. Okay, of course, wet hands first, apply the soap, right palm over left, palm to palm, fingers interlaced, and then back fingers, opposing fingers interlocked, and then rotational rubbing of the thumb like this, each of our fingers, and then it rotates, and then that's for 20 seconds. Okay, and these are the moments for hand hygiene according to World Health Organization. Okay, the first one is before touching a patient. The second one, before clean antiseptic procedure that a doctor or a nurse will do. The third one, after body fluid exposure risk. Or number 4, after touching a patient. And the fifth one is after touching patient surroundings. Now, a lot of people, a lot of healthcare workers goes into these patients' rooms and they would put their hands like this. And then they would get out, and then we, the police of the hospital, would say, you didn't wash your hands. Because we see them, oh, you didn't wash your hands when you get out. So, I didn't touch anything. And then we would say, but you were in the environment. Okay, and then when you come in other places, touch again. So it's very important. It has to be washing hands in and out. Okay, now the alcohol-based hand rubs. Yes. They said it's good. Okay, CDC approves of it. It requires less time, most effective for standard hand washing than soap. It's more accessible because it's all over the place. You can just go in there and it reduces bacterial counts in hands and improve skin condition. But there are times that we cannot just use that one. Can you change the? In patients that, of course, when our hands are visibly soiled, you cannot just use the hand rub, okay? Because it's like when there's chocolate in your hand and you just put the hand rub, it's just mushing it. Okay, or when you are taking care of a patient who has the C. diff, because the alcohol doesn't kill the spores. You have to wash your hands. Okay, appropriate use of PPE. It has to be proper fit. Okay, most of the time, this healthcare workers it's hanging. It's not covering themselves. You know, it has to really be properly fitted. Okay, integrity of the barrier. Okay, no holes to it. Disposable versus reusable, we always use disposable. Potential for cross-contamination if not changed in between patients. And during influenza season, surgical mask is replaced with moist or when caring for a patient on isolation precautions. Okay, we have to really, it's all over the place in the hospital. We have to use these masks, all these PPEs and everything because it's really available. Proper disposal. These PPEs or the personal protective equipment are removed before exiting an isolation room to prevent the cross-contamination of the environment. Okay, sometimes we see healthcare workers, they remove their PPEs outside the door, which is not supposed to be. It has to be before you come out. Okay. Of course, we still use the PPE. I'm sorry, can you go back? By a staff when they're ambuing a patient going to somewhere. Like for example, the patient is from the floor going to the ICU because they crashed. The person that's ambuing the patient during the transport has to wear the PPE because they're very near the patient. We allow that. Or when a physical therapist would do a therapy session with the patient by ambulating them, they can also wear that. Those are the only 2 times that we would allow them to use. Okay, you can change them. Okay, the environment, when it's inadequately clean, there comes, you know, the touches, you know, all these areas are when improperly storage and handling and failure to reprocess or dispose of equipment between patients, infections occur also. In the hospital where I work, Nassau University Medical Center, these are the stuff that we use. The Ultima or the Quaternary 10-minute contact and the bleach wipes. Okay, there's an area in the hospital, the 5th floor, they just use bleach. Or in some other places, okay, because they just really don't want infections. And we have the sunny cloth or the purple wipes we call, and this is the bleach wipes that kills the C. diff. Okay, and these are the non-critical items that we use the purple wipes into, like the blood pressure machine cuffs, the IV poles, you know, all these iMed machines, those mattresses and all those things. Those are the things that we clean in between patient use in the hospital. Okay, the ATP luminometer. In the hospital, there's 2 departments that has this one. This is a thing that we use to monitor the cleanliness. Sometimes when housekeeping people cleans a bed, okay, patient gets discharged. They clean the bed and it's all done. Before the nurses would put the linens in, we come in, or housekeeping comes in and test it. There's like something that we put in there and test it, and if it's like less than 50, according to the manufacturer, it passed, that it's clean. But if it's over 50, then it has to be cleaned again. Okay, so that's the thing. Of course, when we use computers in the hospital, we always have to really make sure that we wash our hands, because a lot of people, as what I said earlier, only 50% of healthcare workers washes their hands. When they use the computers, it's like a farm of organisms in there. More? Okay. Infection control is everyone's business. Patients, doctors, nurses, CNAs, all of those people as being mentioned in there, administrators, it's really everybody's business. The families. So be a lifesaver. Do a hand hygiene. Thank you very much.
Thank you.